The Evolution of Outcomes-Based Competencies in Medical Education by Eric Holmboe and Constance Bowe, in collaboration with the Harvard Macy Institute.
I'm Dr. Connie Bowe. I'm a pediatric neurologist by training, but I've been a long-term member of the Harvard Macy Institute, and I co-direct the program in a systems perspective on assessment in health professional education. I have the honor of introducing Dr. Eric Holmboe, whose current title is Senior Vice President at the Accreditation Council for Graduate Medical Education, which is one of our regulatory bodies in the United States. But more importantly, Eric has been a longtime champion of improving medical education as a contributor to patient safety and the quality of care that we provide to patients. Welcome, Eric.
Thanks. Looking forward to this.
I think it would be useful, since we have a relatively international or potentially international audience, for you to maybe explain briefly what were the goals and the objectives of the initial outcomes-based competency movement that you've spearheaded.
Well, you're being way too kind. I actually haven't spearheaded it, but I think you can go back actually a number of decades. Really even back into the 1960s and 1970s, when there began to be this realization that we needed to focus more on what physicians actually do and not just how they've been prepared or what they know. In fact, you can go back to a World Health Organization white paper in 1978 that talked about the need to prepare physicians to meet local needs. So really focused on the needs of health systems and populations. That was kind of the first thoughts about where medical education need to go.
And you've been involved in this process for 2 decades by my calculations. And I'm sort of wondering if you could maybe briefly, for places that might be interested in getting more insight as to how you even approach a change in healthcare education on the magnitude that you've been working in.
Wow, that's an interesting question. I think you have to look at a number of kind of forces that were in play that have kind of led us to this moment, as you know well from your work in systems. I think one of those forces was the kind of growing concern around the quality and safety of healthcare. We know that started actually in the 60s and 70s. There began to be some studies, and then in the 80s we really began to see an acceleration of the concern with the introduction of quality measures. The National Demonstration Project is one example of that. And then actually CMS embarking on a different approach to how it actually looked at the quality of hospitals. Concomitantly, you had these really important papers come out demonstrating the quality and safety issues within the healthcare system that culminated in the 2 seminal reports, To Err is Human in 1999 and Crossing the Quality Chasm in 2001. People then began to look at the medical education enterprise as a solution to help drive better quality and safety through better preparation of future physicians and other health professionals as well. That led to the rise of the competencies. The first actually was a set of competencies was in Canada, which was released in 1996, known as the CanMed roles. And their catalyst for developing those competencies, believe it or not, was a doctor strike in Ontario that then led to a conversation between the profession and the public about what the public expected, and then the CanMed roles were first rolled out. We began our competency development in the mid-1990s, again, kind of in concert with the quality and safety movement. That led to the release of our competencies in February of 1999. So it's been 17 years since the competencies were first published. And the Outcomes Project that was started by my organization was formally launched in 2001.
And so even this term outcomes may not be familiar to everybody that's listening to this interview. It does have its roots in systems theory, but that evolved from initially focusing on the manufacturing system or sort of routinized linear kind of processes. Was that a handicap to be talking about outcomes? I mean, I know I also lived through the managed care, the introduction of that when we stopped talking about patients and began talking about customers. A lot of physicians found that offensive. Was that the kind of thing that you encountered?
To some degree, I think that's true. I think the other thing that relates to that is, in thinking about systems, is looking at our graduates as kind of a product, right? Much in line of kind of mechanistic thinking, that it's a machine, the machine produces this product, and the product is put out into the system. And so I think there was some piece of that, and people thought that we lost some important attention to things like, the humanities or humanism, professionalism, et cetera. And so I think there was some of that, yes.
But actually, it's the outcomes movement that really refocused us on not just the accumulation of knowledge, but how it was used to be sensitive to patients and empathetic, the concept of professionalism. Mm-hmm. Did you get pushed back to those things?
I think in the areas of kind of the communication skills and professionalism, our two competencies are interpersonal skills and communication, and professionalism, not so much. I mean, I think they were still things that physicians and trainees could identify with. And I think another thing that really helped was the Charter on Medical Professionalism, which was published in 2003, which is a joint effort of a number of organizations and endorsed by many organizations in the House of Medicine, if you will, which really kind of laid out important principles and also kind of 10 commitments to professionalism. So that, I think most people really kind of bought into. I think what kind of undermined, you will, those things were really what particularly trainees were experiencing in the course of their education, and that became known as the hidden curriculum, right? So I'm taught these things are really important, I have a lecture on it, I go out onto the wards and I experience something very different, right? The disruptive physician, being belittled, degraded, watching patients not being treated well, or
they
poor
are pretty
communication.
Idealistic when they come in, aren't they?
Yeah, and we do a pretty good job of beating it out of them, right? So they come in with pretty high ideals, and then they experience, something quite different from their expectations, and that discordance or dysphoria can be actually very unsettling.
So as the movement progressed, there were certification criteria that were introduced, but for the institutions sponsoring these training programs at both the undergraduate and the graduate level, they were coming under more scrutiny. 10, 15 years down the line, where are we? What progress do you see as having been accomplished?
Yeah, in all honesty, I still think we're in pretty early days, but I do think there's been a number of things that have happened that are really important to highlight. One, I think what you've just highlighted is that the importance of the environment, the institution, matters a lot. In fact, when the ACGME reconstituted a task force to look at duty hours after the 2008 Institute of Medicine report, one of the things they recognized is that what was equally, if not more important, was the environment in which our trainees were currently being educated in. That led to something called the Clinical Learning Environment Review Program that now basically serves as a formative or feedback component of the accreditation system to help institutions understand what the experience is of the residents and fellows, particularly in things like professionalism, quality, and safety. Now, that's really important.
So what are they finding? Where are the trouble spots, or is it different for every institution? Or we don't know yet?
There are some general themes that are coming out right now. That data is being analyzed. In fact, we hope that the first national report on the CLEAR findings that involved nearly 300 visits or visits to 300 institutions will be out within the next 2 weeks. So I encourage people to take a look at that. I can just tell you one thing that we're seeing is we're still not seeing the kind of involvement of residents and fellows in the quality improvement activities of the institution that would be not only optimal for the institution to see them as an important member of the team and participant and to learn the skills they need, but they can also provide solutions. Residents and fellows often see things in the system that faculty and others don't because of what they experience on a daily basis. The second is also probably would like to see more in the way of reporting near misses and actual errors. The residents and fellows, again, it varies by institution, but are not quite as involved in reporting as probably they could be. And again, they're a rich source of really useful information for institutions. So I think those are two things that we've seen, and the report will really lay out more of the detailed findings here in the next few weeks.
And you remind me of an important change that I've noticed. It used to be that there were these periods of 5-7 years when programs would suddenly begin, because of pressure from external accreditators, look at their programs, make some changes, and there would be almost an immediate change, a better feeling, and I think of it almost as a placebo effect, in part because everyone at different levels of the organization participated into these discussions. And then the focus of the institution turned to something else, and you started to see this deterioration. And each of these curriculum reforms or program reforms tend to be pretty disruptive. Is this new approach and the amount of information we're getting from our programs likely to change that cycle?
Well, we certainly hope so. I think you've highlighted what was one of the limitations of kind of the old approach to accreditation, where, like you said, you prepare for this deep dive. You usually get a site visit anywhere from every 4 to 6 years, depending on your cycle. And then there'd be this frenzy of activity to make sure everything was in order. And there
or it looked like it.
Yeah, there was some good that came out of it for some. I often had people say that the reason they liked it was that they could leverage that visit to get resources from the institution. But in reality, it was too often playing to kind of the lowest common denominator. Not that minimal criteria aren't important, like making sure the residents are treated well and there's adequate food and the kind of basic structural elements of a program. But it certainly wasn't getting us to where we wanted to go in the concept of outcomes, right? So the outcomes is really to drive making sure people can do the things we want them to be able to do as they enter practice. So that was a big fundamental shift, and now we have annual reporting that I call kind of the safety net, where we do have residents fill out surveys and faculty fill out surveys to make sure that, again, there's a respectful climate and there isn't any abusive behavior going on, those sorts of things. But the other part of the system now is much more formative in the lens of continuous quality improvement.
Yeah. And what can you explain why that may be of more benefit than waiting till things have deteriorated to a point where you want to change the whole direction of the ocean liner, or as opposed to making small incremental changes?
Yeah, I think in some respects it could be a combination of both, right? So there's always some refinement of things, and you want to continually take a look at that, right? And so the metaphor here would be the concept of the rapid plan, do, study, act cycle. You're always making things a little bit better and studying it because things evolve.
So you're suggesting we introduce a change and monitor it closely and
yes,
then improve it a little bit.
Yeah, and I think one of the big challenges for medical education is that we've not either fully developed or embraced the need for program evaluation, right? So you put a change in place in your program, it's important to study whether or not it's actually making the difference that you hope it would. And what tends to happen is then people hang on to stuff and they get frustrated with it even when it's not working, when the right decision would be let it go, get rid of it. And we hope people will, as they iterate, understand there's certain things that it's perfectly okay to let go.
Yeah, I know that we've written a lot in the U.S. and Canadian literature about some of the advances we think we've made. It concerns me sometimes when I see other countries, other contexts, just trying to copy what we're recommending here. But you have this global sort of viewpoint on it. Is it working in other places? Are there precautions you recommend they take in implementing some of these best practices that we advocate for?
Yeah, well, that's actually an interesting and actually quite deep question, because there's a number of components to the question. The first is I think we need to move away from the concept of best practice because practices need to change. So I like the concept of notable practices, what appears to work. I think the second thing that you're alluding to, that when we look at whether or not something's working, we always need to ask a series of questions. And this comes out of the complexity approach to evaluating programs. It's what works for whom, in what circumstances, and why. So context matters, right? So the context in Singapore, the Middle East, or Europe, wherever you may be, does play an important role. Who you care for is an important part of that context, right? And the nature and the type of diseases and the disease burden may be very different, for example, in sub-Saharan Africa than it's going to be in the US or in Singapore. Those have to be part of the conversation in designing curriculum. In fact, one of the things I like about the philosophy of an outcomes-based approach, and this has been nicely highlighted by others, is that you start with the health and healthcare needs of the system and the people you serve. The competencies and outcomes should flow from that needs analysis. And then the last thing that should be developed is the curriculum and the assessment program. And they should be integrated to basically be able to tie into those outcomes and competencies that are related and tied into what the health system needs are.
So if the patient, the quality, access, costs of patient care are really the foci of this movement, how does an educational program know when they're at least headed toward making progress toward providing that care that society and patients want?
That's a great question. So I think there's a couple ways, and I think you're alluding to the triple aim, which I think applies globally as well as the United States. You know, the health, per capita costs, and then the 6 aims of quality that we often talk about. So I think there are a couple things a program to do. Number one, understand what the needs are of your local or regional population, because that's who you're going to see in the program, right? So if you don't fully understand what it is the local population is experiencing, I think that's a challenge. The good news is we're swinging back to an interest in population health. I'm actually really excited about that. Recently, the CDC just released a series of milestones and competencies for population health that everybody can download and use. I'm glad to see that because I think we need to go back to that a little bit. And again, you have to understand who you're caring for. That's number one. Second is, even though they're imperfect and we have a lot of work to do, look at your quality measures. See how you're doing. They're still helpful, like how well you're taking care of your diabetics. And also, here's a really...
You mean in the country?
No, in the country, even in your region. You can use that data. And here's a radical thought. Why don't you ask your patients what their experience is with their care? So we tend to think like, well, you really can't attribute, patient service to a single, resident or fellow. And, they don't really understand quality. And like, well, you know what? The literature is pretty clear that, for example, patients who experience health providers with better communication skills, they actually do better. That's number one. Number two, it's not just about satisfaction. They have experience about were they well informed, were they activated to help care for themselves, those sorts of things. So we're going to have to tie and use much more of those type of measures. And then I think the next thing on the horizon that I'm very excited about are these things called PROMs. These are patient-reported outcome measures, which really target functional status. So for example, you had a hip replaced. It's great if you don't have a blood clot or an infection, but in 6 months, can you walk? Is your quality of life better? Are you doing better? Those are important measures, and even if you can't quote attribute to the trainee, we can certainly see what the impact is on patients and feed that back into the educational system as part of our learning.
Well, you raise an interesting question. I think in many places in the world, the accountability of governments or the healthcare politicians to be collecting these data on the outcomes of the healthcare system. But at least at this point, how closely are they being tracked back to the educational experience of the providers, and how do you begin to do that?
Yeah, so we're in the very early days of that, and I think there has been a couple early studies. There's been a little bit of work done looking at the performance at the institutional level and how that actually correlates with the future practice of physicians who trained at that institution and how they're doing. So we've seen correlations with obstetrical complications, surgical complications, cost of care in various disciplines, as well as how well they manage patients when the right answer is conservative management. We're beginning to build this body of evidence that where you train actually has an impact on what you ultimately go out and do. So that's one bucket. The other work that's beginning will begin to look at practice and then correlate it back to the assessments made during residency. This is what we're beginning to plan for with milestones. So as these milestones are the way that we describe the competencies in the United States, and soon Canada will do something similar, and we look at these developmental levels, we can then see how well did they, in a sense, predict how that individual is going to do. And because we have these data sets that we can tap into, like Medicare and others, we'll begin to do that kind of research, and we're just about there. This June will be the first cohort in internal medicine, emergency medicine, and pediatrics that have been in the milestone system for their entire residency. So this will be the first cohort, and so moving forward, we'll begin to be able to follow these groups of individuals out into practice and see how they do.
Now, it would seem to utilize that information and make the changes that they at least suggest should be, resources need to be available. So are the resource allocators nationally or even institutionally on board for this? You see them as being responsive?
Yeah, that's a great question. I mean, I think right now that's still an ongoing conversation that's had its tension points over the last couple of years. I think catalyzed by the Institute of Medicine's report last July looking at governance and finance and GME. I think there's definitely an interest and will among many around the importance of this. I think figuring out the logistics and how to operationalize that conversation will continue, but there's no question, at least from where I sit, of the interest and people seeing the need for that. And if I could say one more thing, part of the reason is we now, and you know this as a systems thinker, that we haven't had these kind of feedback loops into our programs. The only feedback programs have had really has been, did they pass the certification exam or not? And again, knowledge is really important. You can't function with an empty hard drive. But on the other hand, you know, these other things like systems-based practice and quality improvement and care coordination, things that, you know, you and I've talked a lot about are important too. And so seeing where people are when they finish and then following them out and then feeding that back into the program. So there's the internal feedback loops within the program that are critical, but now we have these national feedback loops. We're now beginning to do that. And so I'll just give you one quick example. To me, it's been really exciting. So in the initial data looking at neurosurgery, which were one of what we call the phase 1 specialties, we found that a number of their residents had not achieved, in the judgment of their programs, level 4 on the milestones rubric for the competencies in a number of the surgical domains. And they're grouped by various types. You know better than I do as a neurologist, epilepsy surgery, you know, trauma, etc. And so, you know, your first reaction might be like, oh, that's awful. Well, no, actually, it was incredibly powerful news. What it's helped that community to understand is that, you know, they have various curricular issues. It also has led to the question, like, so what exactly is core neurosurgery training? We now have this as a feedback mechanism. This is what we're saying to ourselves in these other areas. We didn't have data before. And yeah, it's really messy. We have a lot of work to do. But it's catalyzed some really interesting conversations in neurosurgery and other disciplines we've just never had before. So that's what I'm really excited about.
It's encouraging. I'm thinking of a recent article that you and Paul Batalden put out, sort of outlining where the process has been and sort of how it's moving forward and some of the obstacles and pushback that you've gotten. As a group, have the group of advocates learned any lessons, and have you any suggestions for places that may be wanting to initiate a process something like this, but with reducing maybe the pushback?
Yeah, I mean, and again, you've done a lot of work in this area. What I'm really struck by is how hard it is to let go of stuff. And so I think that we have to begin to help people see that what may have worked in the past is no longer as effective. It's not to say that what happened in the past wasn't really useful, because I deal with a lot of what I call nostalgialitis imperfecta profunda, where, you know, people go back and they very nostalgically think of how great their training was. And look, don't get me wrong, I love my medical school, I love my residency, but when I look back, there were a lot of holes in it. And so we have to, you know, understand that what's needed today was not necessarily what was needed then, or at least things have changed. The other tension that's always in play is, you know, you have George Santayana's admonition that those forget the past are condemned to repeat it. And there are definitely parts of our past I don't want to lose. The other, I'd just say real quickly, is Francisco Varela, who said the blind spot of contemporary science is experience. And his point is, if you only lead from what you know, it's pretty hard to imagine a different future. Yeah. There's also a lot of emotion around this. I love the concept that change isn't really about change. Change is about loss. You know, there's a lot of emotion involved and a loss of identity and stuff that's been successful for many of us may not be as effective anymore. So how do we not only learn new things, but the other part that's really difficult is how do you unlearn, right? And unlearning is not an easy process. And so it takes help. And we need to have more of those kind of open conversations, in my view.
So more input from an invitation for all layers of an organization to participate.
Absolutely, yeah.
I think one of the things that you mentioned is that it's to distinguish between what are the changing values, of which I don't really hear much. It's the methods to promote them. And people, if they confuse those things, they see change as losing the values as opposed to just a different approach.
Yeah, and I think some of the values are under a bit of duress. I mean, I can't help but harken back to, I believe it was Engelfinger's article about the commercialization of medicine and the medical industrial complex, I think in 1980 or around there. And his fear about the commercialization, I think some of those fears have been realized, and they're definitely creating, again, that dysphoria or discordance upon the values we espouse versus the values we often live or experience. And I think that's where some of the cynicism, for example, has come around professionalism, from students, residents, and fellows, because we espouse one thing, they live something different. So I think we're gonna, that's something we're gonna have to grapple with. I actually think medical education's in a really nice spot to have that conversation, right? That's deeply part of our roots. And it's part of the academic tradition. So I think your point about having a conversation across the organization and bringing people together that normally don't talk together, I think is really important. And that also triggered a thought that we talked about earlier. To me, one of the more powerful things about the Milestones Project wasn't the end product per se. It was the conversation the communities had, and that was deliberate. It's hard to believe we started this in 2007 in internal medicine, and being a typical internist, we were really focused on the end product. But as we reflected back, we put out the first set, what we realized is that it was the first time a large swath of the community had actually had a conversation about what an internist is supposed to look like, right? We had 390 programs, give or take a few, and we had 390 different ways of imagining what an internist was supposed to be, right? Again, there was obviously some overlap, but that for many of us was kind of a stunning realization that we've been all working in this field, and we didn't have a shared mental model about what an internist is supposed to be, or a pediatrician.
It's a little hard to create one.
Yeah, and so you can't do that in isolation, and so this is where the conversation, just the interaction, and the community involvement, to me, was probably the more valuable part of the Milestones development, this kind of first phase, than what came out of it per se.
Uh-huh. Well, there certainly has, in my short professional life, I can see the change between the focus on medical education and the number of people that are actually making careers out of that, because suddenly it's assumed a level of importance, which is really reassuring that we will continue to train good doctors.
Yeah, I think you see the explosion of these master's program. I think in the number of people acquiring advanced skills, to me, is really encouraging. And the reality is we need it. We really do. I mean, it used to be that, well, you're a nice person, you're a good teacher, so therefore, guess what? You get to be a program director.
And or if you're the junior one that brings in the least revenue, that's...
that's the other way. Well, I was in the military when I became a training officer. I'll never forget sitting in Steve Buttel's office as the chair, and also Rich Hawkins was with me at the time, and he says, listen, Eric is training officer. Your job is to sit down and go over their file twice a year. And I'm thinking okay, how hard can that be, right? I'll just sit down and talk with them. So, January rolls around. It's my first time, and I pull out their evaluation files. And of course, they're just completely useless, right? So everybody in a 9-point scale is 7, 8, or 9. Doesn't matter if they're an intern or a senior resident. And most of the narrative that's provided is nice person, read more, consider for chief resident, would work with again. I'm looking at this, I'm like thinking, all right, I'm just going to put read more in every one of the forms, because you know what? I've never met a physician that shouldn't read more, right? So let's just take care of that. But I realized I was completely clueless, and this was a useless activity. It was nothing more than a screening tool. So if you got a 5 on a 9-point scale, that was really bad. Even though it says satisfactory on the top of the form, no. That's a red flag. You're probably in trouble. It was a crazy system. And I said, there's got to be a better way to do this. And that's how I got into assessment. It was just because I felt so bad that I had nothing useful to say to these folks. Yeah, it looks like you're doing fine. Any questions? All right. Well, that took 15 seconds. I'll see you in 6 months. So I think that's the other thing that's really changed. Instead of this kind of proxies and ad hoc, like how well you present at morning report, do you show up on time, can you present outside the patient's room, we're now moving to hopefully more observation, which is a better part of our past, right?
Yes.
Observation and coaching is where we came from. That was a major part of training. And we lost that with the rise of specialization and just the growth of programs. It's tough to observe when you have 170 residents in your program. You have to really be deliberate about how you do that. But I think we're beginning to see that shift come back as well. I think that's a good thing.
Well, Eric, I'd be derelict in my duty if I didn't ask you to put on your wizard's cap and tell me what I can expect in the next 10 years.
Well, as you know, predictions are really dangerous, and I'm no Merlin. But I do think we'll see some additional work, and so maybe I can just lay that out a little bit about what I know is actually going to probably happen. The first is with regard to the milestones. We'll continue to do the research work, particularly study the validity, and really try to understand the system. We've made some major changes to the system, in addition to rethinking assessments and how they fit, using much more of a programmatic lens. We certainly have this group process called the Clinical Competency Committee, where we're using more group judgment to kind of make what are called entrustments. In other words, do we entrust somebody to go out and practice without supervision? There is clearly research that's ongoing now and will continue, and that's part of our research strategy at the ACGME.
And I guess in terms of systems, there's certainly medical education research that needs to be done in as controlled a setting as you can ever do developmental educational research. But the other message I took away from what you said is we can't always wait to make changes that appear to be needed in our systems until all the votes are in. But in fact, this call for more innovation in medical education is really these iterative small changes that just keeps improving things. And as of yet, we don't really have a good vehicle to communicate that to people with details about the things that supported them in our system and the things that may have, limited the benefits.
Right. No, I think the other big thing that you'll see is really creating dissemination strategies and what I call more connector strategies, and we're doing that. For example, we have faculty development assessment. We've now built out several guidebooks. The other thing, there's 2 big initiatives. This is an opportunity to talk about. So the CLEAR just announced its initiative to catalyze innovation. There'll be 20 small grants given to institutions to really look at innovative ways to involve residents and fellows and others in quality and safety. We've also just approved, and we're now getting ready to launch, an innovations pathway for training programs. So if they really want to think outside the box, there's a way to submit a proposal to get relief from the usual accreditation criteria to really innovate. So we now have these 2 new major initiatives. We're trying to catalyze innovation. The other thing we're going to do, instead of just letting it sit out there, is we're going to serve as a hub to try to get those things that we learned back out into the community. So we talked about those feedback loops. We really want to serve that role. We don't build most stuff, right? That's not what we do, but we can certainly connect people to good stuff through these various mechanisms. So I think you'll see that. I think the other thing you alluded to that will continue to drive changes that we're going to have to learn as we go. So we're going to have to use some of these complexity models to study program interventions, more of the CQI process where you learn and iterate as you go along instead of the typical randomized controlled trial. There'll probably be some of those, but that can't be the only way we go about studying change. So as the other thing I think you'll see is a greater aligning of thinking about educational outcomes, which are defined by the competencies and the milestones, with clinical outcomes, and try to begin to better integrate all the changes happening in clinical care delivery with educational outcomes. There's another grant going on right now that really is studying how well internal medicine, family medicine, and pediatrics can work together to advance clinical care redesign and educational redesign in the ambulatory space, which is a huge need, as we know, for a system. And this is really bringing those two worlds together, using kind of patient-centered medical home concepts with new educational concepts and studying that. So I think you're going to see more of that kind of work moving forward, merging the clinical care and educational systems closer together and more integrated, taking a look at more innovation. I think there's now a number of catalysts out there. The ACE program at the AMA is a nice example, right? Those schools are doing some really cool stuff. And in fact, they've been so successful, they have schools that just want to play. They're not asking for any of the money. They just said, can we play? Because, that's really exciting. So you have all this you and me stuff happening. And then you've got some pilots looking at kind of accelerated pathways or combined pathways in pediatrics and family medicine. So we're now seeing, this kind of drive of innovation really begin, I think, to gather some steam. And what I'm hoping is over the next 3 to 5 years, we'll begin to call more lessons out of those projects so that we can then, again, feed them back in and saying, hey, this, depending on your context, this is something to think about. And so we'll have more and more shared resources and activities. I'm seeing more of that happening in some of the surgical disciplines around shared curriculum and kind of assessments, and more conversation among the program directors and the programs than we've seen in the past. I think that's really wonderful. So I see that continuing. Where it ends up in 10 years, I'm not smart enough to tell you with any certainty, but I do think we're going to see some exciting stuff. I really do.
Sounds like it'd be fun to stay around for the ride.
I think so. Despite the kind of chaos and frenzy right now, if you will, I think it's a great time to be a medical educator. I really do. And I think there's wonderful opportunities for folks to get into this. And I think as we learn the importance of education as part of the solution to improve quality, that's going to continue to gain hold. And I think, what's happening here at the Harvard Macy Institute is just phenomenal. And you guys have had such an impact that I think those lessons are going to increasingly be applied. And as I recently wrote, I think where we are now is not whether and why we should do this. We're now in a phase where it's how. How do we do this? It's the how. And now I often liken this to the bench to bedside problem, right? It's a translational problem. We have some pretty good theory now. We have some pretty good concepts and tools that we can use, but implementation is hard, messy work. It just is. And it's hard enough getting people to prescribe a pill, right? Remember the beta blocker story, 17 years for it to be adopted? We're no different. It's ironic to me when I look at the beta blocker story, it's been 17 years since the competencies were published. So we're in this translational phase now, and I see that as really where most of the work is going to be moving in the next, at least 3 to 5, if not 10 years.
I'd like to thank you very much for giving us this
thanks
time and for your participation in our program.
Yeah, thanks for having me.
Big addition. Thank you.
Thank you.